Good evening, everybody. My name is Dr. Tariq Kapasi. I'm a partner of Willows Health in Leicester. Thank you so much for attending this Willows Academy webinar on coronavirus in children. This webinar series is from the teaching branch of Willows Health, which is a primary care organisation in Leicestershire. We've very much felt a need during this pandemic to deliver engaging, relevant topics in a platform which is easy to access. And I'm hoping very much so that we can fulfill this need through this series. Now, I think it's important just to go over a few house rules to ensure everybody's experience is as optimum as possible this evening. First of all, if you could keep your microphones and your videos off, that will mean that we will minimize interruptions through the course of this evening. We very much hope to upload this webinar onto YouTube later, and so that's going to be available for everybody to see. Thirdly, I'm sure many of you are going to have questions through the course of this webinar. If you do, put it onto the chat. Just be mindful that some of the questions that you may ask may be answered through the course of the lecture today. I'm really quite delighted to see that we've got so many people logging in, and perhaps that was as a result of the successful webinar we had last week. So just as a reminder, last week we had Professor John Bennett join us, who was chair of the British Thoracic Society and also a consultant respiratory physician at the Glenfield Hospital in Leicester. Now, this week we've got a team of paediatric experts joining us from the Leicester Royal Infirmary, and I'm really excited about this one. And I think the fact that we've got people joining in from all parts of the country is fantastic. And I think it was this pandemic that allows webinars like this to occur, so we can share that cross-speciality expertise and learning to improve the lives of our patients, but also for the joy of knowledge. What's very much apparent through this coronavirus pandemic is the resilience and adaptation of the medical profession. And I think it gives us an opportunity to change the culture by which we practice. Perhaps we need to be better at working together between specialities, and I'm hoping today is only one part of that puzzle. Now, moving on to the actual lecture discussion today is coronavirus in children. Now, I think we've got lots of attendances today also because there's a thirst for answering many questions that we have around this topic, simply because there is perhaps some uncertainty around it. Now, uncertainty can cause anxiety, and anxiety can be predominant when we are looking after children, particularly in primary care. Now, one of the groups thought to be relatively unharmed by this pandemic is children. A few weeks ago, though, we learned of an uncommon but severe association with a Kawasaki-like disease causing a paediatric multi-inflammatory syndrome. This was a cause for alarm when many clinicians have read of this association. What was more concerning is that there were a series of alerts coming through from London about the number of children presenting late into a non-coronavirus related illness, making them very unwell or even dying as a result. A few weeks, though, is a really long time in medicine, and there's been a significant amount of work performed to try and help better define this risk. Today, we have got a team of paediatric experts joining us to share their expert knowledge on COVID in children. So whilst we were planning this webinar series, we were thinking about inviting a team of paediatricians. In truth, it was a coincidence I'd met one of the consultants, Dr. Atkinson, who put together a team to organise this webinar today. A few weeks ago, my wife and I woke up to find our 2-year-old daughter with an empty packet of paracetamol in her hands. Of course, I lost every degree of medical objectivity. We took her straight to A&E, and we were relieved to find her paracetamol levels had come back to normal, in fact. There are lots of things that we learned through that experience. 2-year-olds are particularly resilient, and they can find paracetamol in places that you thought you would have had it hidden. There's also a few things I learned whilst visiting the department. Firstly, the degree of operational skill in managing a department such as paediatric A&E during COVID, but also the impact of a simple smile on the face of a clinician and the impact that has on an anxious parent. So our speakers today, and a panel of speakers rather, include Dr. Amy Atkinson, Dr. Deepa Patel, Dr. Gareth Lewis, and Dr. Catherine Nunn. So without further ado, I am going to present the floor to Dr. Patel, who is a senior paediatric registrar working at the Leicester Royal Infirmary. It's been a real privilege to work with Deepa in the past, and I've actually shared the crash bleep with Deepa on many occasions. So Deepa, how are you this evening?
Hi Tariq, thank you. Can you hear me well?
We can. So do you want to proceed to your presentation, and then what we'll do is leave the Q&A segment towards the end of the webinar today. Thanks Deepa, I'll leave it to you.
Sure. No worries. Right, so thank you Tariq for sharing this platform with the paediatric team at UHL and giving us the opportunity to share our experiences of managing COVID-related disease in paediatrics. I also want to thank everyone for listening in this evening after what I'm sure is a very busy day at work.
Deepa, just to interrupt, I think there is your voice is bouncing, so I don't know whether you've got two audio sources there, just so it becomes a little bit clearer and we can hear you. No problem if not. Just speak once again, Deepa.
Is that better?
Much better. Thanks very much.
Great. Oops. Okay. So, essentially, PIMS-TS, which is short for Paediatric Inflammatory Multisystem Syndrome, temporarily associated with SARS-CoV-2, is very topical at the moment after the UK reported a cluster of paediatric patients presenting with a Kawasaki-like inflammatory syndrome. Alongside this pandemic, we have obviously received, unsurprisingly, all this significant media and Royal College coverage about this Kawasaki-like syndrome, and has understandably caused concern for all clinicians who encounter children in their clinical practice. Bearing this in mind, I have tailor-made this presentation together with Lorna Green, a GP trainee, to give you an insight into our experience of PIMS-TS and how this is relevant to you as clinicians in primary care, where you are likely to be the first point of contact for a myriad of symptoms. So I will start off with a short case presentation, followed by our overall experience of PIMS, and then outline the Royal College case definition and how this applies to GPs when considering PIMS, TS, or safety netting appropriately. This is a case I encountered a few weeks ago involving a 16-year-old Asian boy who was referred in by his GP for a 5-day history of fever, malaise, and a generalized rash. When he presented to ED, he was found to be tachycardic, pyrexial, and lethargic. Interestingly, he had bilateral non-prevalent conjunctivitis and a widespread macular rash. Systemic examination was otherwise unremarkable with no other red flags. This slide outlines his observations. I particularly want to bring your attention to the heart rate, which was persistently above 110 in the early part of his admission.
Deepa, sorry, just to interrupt. I can't seem to see that slide.
Okay. Is anybody else having that problem? Because I can see it.
It may just be a problem with
no,
me. So
they're not moving. No, the slides are not moving. It's a common problem in MS Teams.
Right. Is there any way of overcoming it?
I think just proceed with your presentation, Deepa, and hopefully the bandwidth will catch up. I suspect it's also to do with the number of participants we have. Okay.
So this slide actually just highlights his observations, and what you would be able to see is a heart rate which is persistently above 110 for a 16-year-old boy, and an unrelenting fever up to 40.7. Based on this presentation, he was covered for sepsis with fluid resuscitation and ceftriaxone, and a diagnosis of PIMS-TS was suspected, which led to a multitude of biochemical, microbiological, and radiological investigations carried out. I don't know if you can see the slide, but essentially, This slide summarizes investigations for this young man. And what you see here is a typical blood picture of a patient with PIMS TS with a CRP of 374, a high white cell count with neutrophilia. This, together with a raised interleukin-6 and ferritin level, is indicative of a cytokine storm and high risk of septic shock.
Deepa, sorry to interrupt again. Are you sure you're sharing the right screen? Because that might be one of the issues, because the presentation hasn't caught up. It's just that you've obviously done a lot of work on these slides, and it would be a shame not to share them.
Okay, let me just try and reshare the screen.
Fantastic. That's catching up now. Brilliant.
Yeah, it's still on share. Can you see that?
I can, yeah. Brilliant.
Is that okay?
We can. Thanks, Deepa.
Okay, great. The other point of interest was that there was raised troponin and BNP levels, which is indicative of the myocardial stress and damage that precipitates the hypotension. Blood cultures and virology was negative, including tested for COVID-19 PCR on 2 separate occasions. And by day 2 of admission, there was already evidence of Wright's coronary ectasia. Within 36 hours of admission, this young man deteriorated with ongoing tachycardia, hypotension, and rising lactate. He received aggressive fluid resuscitation and was transferred to ITU for consideration of early inotropic use. He received IV immunoglobulin and aspirin to diminish inflammation and prevent further coronary artery complications. Fortunately, he did respond well to fluid management, and following treatment with immunoglobulins and aspirin, his fever started to subside and his biochemical markers of cytokine storm also improved, and he was discharged home on day 14. Naturally, the next question is, how common is this? And as a GP, how frequently are you going to encounter it? Fortunately for you, it's very rare, and so far we have had 5 cases at LRI. Only 2 of the 5 patients have tested positive for COVID on PCR, which actually reflects only 6% of all our inpatient COVID cases on the graph highlighted above. The exact mechanism of PIMS TS is not very well understood, but what we know is that this syndrome manifests as an overlap of clinical features between Kawasaki disease and toxic shock syndrome. It's also worthwhile noting that PIMS is not always associated with COVID PCR positivity and may actually be a secondary to a delayed immune response to COVID. The vast majority of COVID presentations we have seen have actually been incidental findings, as you can see with 45% on that graph, and they were admitted for another cause such as appendicitis or cellulitis or safeguarding concerns. So of our cohort of the 5 patients, the age range was variable anywhere between 1 and 17 years. And what's interesting was that 60% of these, although it's not a large number, were of Black, Asian or minority ethnic background. This slide summarizes the outcomes of children and adolescents with PIMS. The main thing to take away from this is that all children presented clinically unwell, with 4 out of 5 requiring intensive care. What we have learned is that despite echocardiogram changes, the need for ventilation or inotropes in some, they have all recovered and been discharged home, and therefore the short-term prognosis appears promising. The final part of this presentation will focus on what you as GPs need to look out for. I thought a good place to start is by looking at the Royal College of Paediatric and Child Health case definitions for PIMS TS. Although it states the importance of inflammatory response on bloods, the COVID result as either positive or negative, and the exclusion of other similar differentials, I have highlighted in red what I think is most realistically relevant to you within the resources you work in. Firstly, the presence of a persistent fever is key, and secondly, single or multi-organ dysfunction with additional features which we will go on to cover in more detail. The red box highlights all children should have a persistent fever, followed by the next commonest as oxygen requirement and/or hypotension. The final box covers a multitude of non-specific symptoms ranging from GI, skin, respiratory, and neurological symptoms. Although this guidance may prompt you to consider PIMS TS, I would advise not to take this slide on face value in terms of guiding all referrals. It is important to recognise that common things are still common. Every child with a fever will not have PIMS TS, and therefore you should still continue to rely heavily on your clinical judgment. For instance, when you encounter a child with a short history of loose stools and fever, which on paper could appear to be PIMS TS, but is more likely to be your standard viral gastroenteritis if the child looks well with normal observations and has no evidence of unrelenting fever. In my opinion, I think this guidance may be better used for raising awareness of PIMS TS as a differential and providing safety netting advice to families. Being on the other end of the telephone, often giving advice to my GP colleagues, I frequently get asked about isolated rashes or GI symptoms and the possibility of PIMS TS. I understand the prospect of missing a diagnosis such as this within the time constraints of your consultation can be concerning, especially given that the symptoms are so non-specific. However, what I can reassure you with is that PIMS TS is highly unlikely in a child that appears well. Finally, the take-home message from this presentation is that PIMS TS is rare, but can have fatal consequences. Reassuringly, our experience shows that these children will present clinically unwell, which is easily identifiable. This guidance will help you consider PIMS TS as a differential, but your clinical judgment remains key. And with that, I want to thank you all for your time, and I hope our experience has given you some insight into PIMS as an emerging disease entity in paediatrics, and I will hand you back over to Tariq for the next part of the talk. Thank you.
Thank you, Deepa. Really fascinating discussion on PIMS particularly. There's a few things that I found really quite interesting. Firstly, the fact that it doesn't really affect many children is a godsend. Secondly, immunoglobulin treatment. I never knew that was a particular treatment modality for the treatment of any patients with COVID. So perhaps we can sort of venture into that towards the end of the discussion. And also that 60% of your patients were from British, rather Black, Asian and minority ethnic groups. And I wonder whether that's representative of the population of Leicester, or whether it actually is an index for an increased prevalence of COVID, severe COVID in such a group. And also, it seems very much that PIMS is really non-specific, and I think, as primary care clinicians, we'll have to keep it within our diagnostic sieve. And very much it seems we'll be having to exercise our clinical judgment as to when to consider it. So thank you so much, Deepa. We'll take a few questions towards the end of this webinar. I'm going to introduce the Paediatric A&E team. So we have a number of consultants presenting. We've got Dr. Gareth Lewis, Dr. Catherine Nunn, and Dr. Amy Atkinson from the Leicester Royal Infirmary Paediatric A&E team. I've had the privilege of working in Peds A&E in the past, and I've had a great time working there. And based on my last experience 3 weeks ago with my daughter, it seems everybody is working really quite hard to manage parental anxiety and do what they can to ensure the operational side of things is kept as streamlined as possible. So I'll hand you over to the Peds A&E guys.
I do. Okay, thanks, Tariq. Hopefully you can hear us, and I'm sharing.
We can hear you, but we can't see you.
You can't see us. Can you see the slides that we're sharing?
I can, yeah.
Well, that'll do.
Oh, we can see you. I can see you. Hi. Smiles, fantastic.
Okay, so thanks for that introduction, and thanks for having us. I think I speak for us all when I say we're looking forward to hearing from these experts that you mentioned as well later on. That's going to be great. So we wanted to take a slightly different tack with the brief, and so following on from Deepa's excellent presentation, we wanted really to present a very practical view for what we've been seeing as the sort of major emergency department for Leicester and Leicestershire with regard COVID, and my hope is that it's going to dovetail nicely, but we'll see from the questions and things. So you've done a lovely introduction. I can skip that, and that should look familiar if you were paying attention. which moves us on to our bit. So from a coronavirus or COVID-19 pandemic in children, we've got a couple of points, only really 3 points. The first being the disease. Obviously, that's the obvious answer to the question, is we want to learn more about the disease process, and I think Deepa's covered particularly some of the previously unforeseen complications quite nicely there. As you said, Tariq, this was, I think, to a certain extent, dismissed as a disease that is predominantly mild in children and healthy young people, and we have had to have a little rethink about that, and that's probably good for us all. What we are finding, and again, Deepa's pie chart exemplified that, is that it is not a predictably respiratory illness. And a really surprising number of these kids are found to be incidentally positive, having been tested on admission for other things. And so that's pretty useful as well in terms of knowing what the underlying pathophysiology of this illness is. The concept of asymptomatic spreaders and the assumption that that's children full stop, I think is still not fully understood.
Yeah.
Okay, sorry. Again, we as a team we work well together, but we can't see. This is the first time we've seen each other's faces for about 3 months, so so excuse us. Unsurprisingly, when we're talking about vulnerable patient groups, the patient groups in paediatrics who are vulnerable to all other respiratory illnesses and infections, so the technology-dependent children, neurologically unwell children, the complex and special needs groups, they are vulnerable to this virus just as much as the others. That's not shocking. PIMS TS, Deepa talked about in further detail, not unreasonably, because they're the kids going to ITU. And I think it's fair to say that we are continuing to learn as we go, week in, week out. We're picking up kids with myocarditis type presentations and fatigability. We're seeing septic babies that are turning out to have COVID as the sole kind of diagnosis. It's really messing us around in that sense. Did you guys want to talk any more about the disease, or should I? Yeah, we'll hopefully cover a bit more about that in the chat. I think certainly my particular anxieties within the locality are arguably more about the COVID-19 response. And I think, again, you've already mentioned, we are all of us innovating and working in drastically different ways. The whole NHS is, and whilst I applaud that, and that's great, we haven't been overwhelmed per se. I do think the concept that children don't get COVID or don't suffer from COVID is a misnomer, because I do think they are suffering to a certain extent from our response to COVID, and that worries me. So we have locally, as I'm sure you guys have with your trainees, redeployed a huge number of staff to adult areas. We are sieving, which is an NHS England directive, prior to entering the ED. So we're picking out fever from not fever, essentially, which doesn't really narrow it down in children. The lockdown itself is presenting some novel new ways to use trampolines and fall out of your house. And this whole concept of remote consultation, telemedicine, that sort of thing that we've talked about for years and years, we've suddenly adopted en masse with actually probably not a lot of training or thinking about it, certainly speaking personally. Working in PPE has thrown up all manner of challenges when you're dealing with children. And the kind of way we manage common conditions has changed dramatically, pretty much overnight. Removal of foreign bodies, access to general anaesthesia and operative management. We're doing as little as possible in those sorts of regards, which has been a huge change. We are seeing delayed presentations, probably not as many as we were first concerned about as a Royal College. There was a bit about some cases in London that were quite high profile, and we have actually contributed to a study on that matter. But it's certainly been anecdotally noticeable that people are thinking twice before seeking healthcare advice. And unfortunately, the nature of paediatrics is such that some children are suffering as a result, sadly. And obviously there's fear, not just parents and patients, but staff and staff groups as well. Some pretty graphs, hopefully you can see. But essentially, our activity has nosedived. We were a 60,000 attendance per year department, one of the busiest in the country, and we're by no means alone across the UK as seeing a huge drop in the number of children coming. But that's only half of the story, partly because we are now running 2 emergency departments effectively, a blue one and a red one for suspected COVID and not suspected COVID patients, and that is challenging because we don't have double the staff. Likewise, the acuity that we are seeing, the reduction in activity has not filtered through to the acuity. So when you look at immediate resuscitation patients, P1s, or high priority P2s, they have proportionally risen during the COVID response. And it's really the P3s, the children who can afford to wait, that we're seeing less of, as you would expect. So our acuity is still pretty decent, and we are seeing some really challenging cases. So we're still seeing lots of things that aren't COVID. Arguably, we're seeing more, and time will tell whether that's a part of the response or the lockdown or not. But one important thing I didn't mention, again, as part of this reconfiguration, we are now seeing 16 to 18-year-olds, another huge project that's been worked up over many, many years that's just been acted on overnight. But that alone is not the sole reason why we're seeing more mental health and deliberate self-harm. Actually, we're seeing younger and younger, and sadly some tragic successes in that regard. We're seeing injuries, as I say, accidental and non-accidental, lots of chokings, or maybe that's just me personally. Surgical concerns keep coming, lots of seizures, and a steady flow of new diabetics. What we are seeing less of, to be fair, is respiratory illness. And so whether it's kids not going to school and not mixing, we would have expected a tail end peak to our bronchiolitis season, and it just fizzled out. That's welcome, frankly, given that pretty much everything we do for bronchiolitis is an aerosol generating procedure, and would mean significant headaches. Ooh, someone's on the phone. So the third thing, so we've got the disease, we've got the response, which is obviously what I can chat most about, and then the what next. So it's becoming increasingly clear that this is not going to go away anytime soon. We locally are strategizing to face at least this winter in this configuration, and we are noticeably getting busier again. Presumably as lockdown relaxes, we'll get busier still. That's not just going to throw up problems. The hope is that we will have opportunities that we can seize and not just revert back to normal. What we're doing even tonight that demonstrates how we are embracing technology, enhancing communication, and hopefully building useful links so that we can streamline services as they get back on their feet, and keep what works out of all this, whilst also there are some services that we do need to get up and running again for the longer term. So that's it. That's my ramble. It's probably worth handing back over to you, Tariq.
Thanks, Gareth. That was a really engaging presentation, and thank you very much for sharing some of the challenges of dealing with COVID. And quite obviously, there are lots of operational challenges in managing COVID in primary care as well as secondary care, both with emergency, acute and routine care. Now, we don't have as many questions as I thought I would get from our floor. So if anybody does have any questions, then please will you put it into the chat part of the Teams, and then I'll be more than happy to ask the guys. So I think we can echo those thoughts in primary care. We're seeing an increased number of people presenting with everything, it seems. I think there was a massive dip, and for that dip when COVID was at its peak, we've never had primary care so quiet. But we knew that there was going to be a rebound after this, and there was going to be collateral damage through those patients who aren't presenting early enough. So we've seen an increase in the number of unexpected deaths. We've not actually had that sort of process to go through the causation of death because we're still waiting post-mortem on these patients, but it will be really interesting to understand the cause of death to determine whether these patients would have typically presented earlier. Fortunately, we've not seen any such significant events in children. And I've got a few questions, guys, which I'm hoping that we can discuss between ourselves this evening. Now, I'm going to come to the transmission of COVID initially in children. I suppose with primary schools opening up this week, and with the paucity of knowledge that's present within the academic world around COVID, there are anxieties that parents naturally have about sending their kids to school, particularly if they live in multi-generational families or families in which there are people who are at risk. So what role do children play in the transmission of the coronavirus? Deepa, shall I ask you that question?
Yeah, can you hear me?
I can.
So I think children at the start of the pandemic, they were thought to be super spreaders, and that's probably on the fact that kids tend to share viral illnesses from nursery schools. They're often always sick, presenting with cough, colds, and fevers. But I think as time has gone on the pandemic, it's becoming more unclear as to what role they actually play as vectors or super spreaders. And actually, there's a really nice article in the archives of childhood diseases where there's an argument to say that actually they may not be super spreaders. And actually, I think the short answer is we probably don't know.
Is the body of evidence
but it's probably
sufficient?
wise to assume that they are, I suppose, to ensure that social distancing and sort of bubbles are adhered to in schools and things. So
let's say I get a phone call from a mother tomorrow. Mom has had, she's on immunosuppression, because she's had a renal transplant in the past, but she's got a child who needs to go to school, and school are inviting her to bring that child back in. Typically, what type of advice should I be giving to that parent? I'm sure there's no right or wrong answer, but we can only base our answers on the knowledge that we have at the moment.
So I guess the thing is, it's always been very difficult to discuss risk with people, even when you know exactly what the risks are. And so in some ways,
I can't quite hear you. Do you mind just coming a little bit closer to the microphone?
So what I was saying is it's always been very difficult to discuss risk with families in a sensible way, even when the risk is quantifiable in a numerical way, because actually people don't really understand that as a concept and what it means for them. You know, the idea that you have a 60% chance of getting the illness, and if you get the illness, you have a 1% chance of dying, is going to mean absolutely nothing to that family, even if you knew those were the figures. So what you have to decide is what the impact of sending your child is to school, what the impact of keeping them is for your at home on your family is. Are you going to be able to stop them from shielding? Are you going to be able to educate them at home? You know, what is the degree of your immunosuppression? Because realistically, we have no numbers to give people. Okay, and so it is just about having a sensible discussion. Yes, there's a risk. We know there's a risk. We don't know what it is. We will never know, even with the numbers, what it is for that family. And that would be true before, after. So, for example, you might argue that the same would be true of flu. What is the risk of that child bringing flu home to that mum, which is going to make her severely unwell? Now, we might be able to calculate the risk, but it means nothing. It means nothing to that family if that happens. So it's just about having a sensible discussion. We know there's a risk. You have to think about what it means for you as a family. Does that?
Thank you. Yeah, no, that's a really useful answer, actually. Clearly, we have a open, pragmatic discussion, give all the information that we know, and then it's up to the patient to consent to sending the children to school or not based on that risk. And I suppose, you know, often as clinicians, we feel as if we need to know all the answers. But sometimes it's okay, perhaps, for us not to know all the answers and actually facilitate discussions and give parents all the information to be able to make that decision for themselves. And perhaps, you know, we may not be the best people to decide whether a child should go to school or not. And actually, our advice might be one of many reasons to send a child to school or not. So thanks very much for that. Now, in terms of shielding paediatric groups, So it would be really interesting to know which groups we ought to be shielding, and I'm sure there is official guidance on this, but you know, we may not need to go into specifics. So Deepa, any groups in particular that should be shielding from the coronavirus?
So I think the government advice, it's not that dissimilar to the government advice. So essentially you're looking for your children with chronic respiratory conditions. So that's your cystic fibrosis kids, severe or difficult to manage asthma, those children that Gareth's already mentioned on long-term ventilation, or children with neurodisabilities. The next cohort would be those that have immunodeficiencies. And this is obviously inherited, but also acquired from immunosuppressive or immunomodulatory treatments. And the other patients that have particularly been in this cohort are the ones who have had solid organ transplants as well, and that's something that's also mentioned by the government advice. And I think the other cohorts of patients should be decided based on the advice from their specialist, either at secondary or tertiary care, and whether they should be shielded, and assess again the risks versus benefits and sort of the socio-economic impact on them as a family.
Yeah, thank you, Deepa, because I suppose, you know, there is an impact on families and mental health, both in adults and children, as a result of shielding. And I'm sure, you know, the subspecialities that you're treating in your cystic fibrosis clinics, for example, give that advice to those children, and I'm sure that's happening across the country. Now, just the sort of a chat about testing in children, and it seems very much that we need serological testing in children to determine how many asymptomatic spreaders we have, and until we have that, it's going to be very difficult to be definitive in the policy that we have in terms of school and how we manage these children. So in terms of testing in children, Prof. Lakhani is asking, we're getting test requests for from parents for children, particularly in the under 5 age group. What should we be telling these parents?
So I think there's a big difference between testing for research and testing for diagnosis and testing for planning. And I don't think really the public has got that as a concept. So if your family is well, you do not need a test, okay, for diagnostic and treatment purposes. However, from a government and public health perspective, if you're looking to see how many people have been exposed or planning for things, then that's a different thing. So it's not up to families to ask their GPs for these tests. It's up to the government to put in, you know, either a wide-based public with population-based sampling or for research, in which case you could then decide who you're going to test on a longer-term basis. So from your perspective, if you've got a child with a fever, and unless there is somebody in that household who you're particularly worried from coronavirus but would not be at risk from any other disease, which seems unlikely, then you don't need to test them because they are just at higher risk from any other virus, such as flu. You know, you need to practice the same kinds of.
But they've extended now, haven't they? So every person, it's not just over 5s, can get a test, and anybody who meets the criteria of fever, cough, or lack of sense of smell and taste will get a test, and so the family will have to isolate until they get that test result back, and that should be a lot easier to ask. So it wouldn't be a necessary attendance at an ED or at a GP practice unless they were otherwise concerned about their child, which obviously if they're concerned about the child, they should always seek medical help. If they've got a fever, they should be organising a test themselves through the government website.
Sure. No, that's really useful, and it very much seems the stance is, well, individually, it's not going to impact the clinical decision we'll make unless that child is unwell from presumed COVID. But on a public health perspective, you know, it does answer lots of questions and help define policy. And it seems that we don't need to, as GPs, adhere to the requests from these tests from these parents. Now, I'm just going to go to a really interesting question by Dr. Shahid, our sports and exercise specialist at Imperial in London. Do you see a similar pattern of demographic presentation in the paediatric population that we see in the high-risk adults, so namely raised BMI, male children affected more than female, and in Black, Asian and minority ethnic groups?
I don't think we've had enough of the complications of PIMS TS to be able to make that call. As Steve said, there's been 5 from Leicester, and that includes children who've been transferred from Lincolnshire and Northampton. And obviously Leicester has a high BME population, so I don't think we could probably make that comment. As far as I'm aware, I don't know if anyone else is. I don't think there's a big difference with children or not, but if Deepa does.
So since the whole pandemic started, we've actually been accumulating data on every inpatient that's had COVID, and obviously this is not going to be reflective of all the cases in the community, but it might give you a snapshot of what we are seeing. And what we have found is the age range is variable from anywhere from 13 days to 16 years, with a median of about 1 year. And in general, the proportion of male to female, so in total, we've had 33 positive inpatient cases, 18 of them were male, 25 female. I don't have the data for Black, Asian and minority ethnicities.
Thanks, Deepa. Deepa, you just mentioned something about immunoglobulin treatment, and I suspect that's not a treatment for COVID, but I'm interested in what context that immunoglobulin treatment was used in the child for the case presentation that you discussed. So
I think a lot of the management strategies has been extrapolated from how we manage children with Kawasaki disease with coronary artery involvement, and also those children with severe toxic shock syndrome. And the mainstay in both, if you've got severe toxic shock, they're needing ITU, and certainly if you've got Kawasaki with coronary involvement, or you think that there's going to be a high risk of coronary involvement, you treat them with IV immunoglobulin as standard treatment. Okay. The difficulty is we don't actually understand Kawasaki itself as a disease entity, so it's even more difficult to understand what PIMS TS is, but we've extrapolated this treatment to our PIMS TS cohort, and it's based on our UHL guidelines as well.
Are those guidelines fairly national, Deepa? I suspect other paediatric teams are doing similar.
Yeah, they are. They are. So there is a Royal College guidance, but each hospital tends to have their own guidelines as well, which you can find quite easily. But for the purposes of the children we see with PIMS TS, we are adhering to the UHL.
Thanks, Deepa. So one common problem we have in primary care is because we're reverting to a digital and telephone first model, we often have appointments for children, young children with fever. And as Prof. Lakhani has asked, it's a very common and challenging problem. And we often utilize video to see the actual child. And we find this helpful because perhaps, based on that assessment, we don't bring them in if there are no red flags. But going forward, and if we just consider the potential for a second wave, home observations would be useful. And Prof. Lakhani is asking, could we recommend these families to have a thermometer to help determine that risk with a bit more accuracy?
Well, I think you can, even just because they'll need to know whether they've got a temperature, even if they're just going to decide whether they're isolating or not.
I think pre-COVID, it would be fair to say.
It would be a reasonable thing to do.
It should come in the bounty bag, frankly.
But the thing that we would also say is it's really useful to know whether somebody has a fever. It's not so useful to know exactly how high it is. Like, genuinely, parents will say, oh, it's gone to 39, like it's a magic number. There are no magic numbers. It's either a temperature or not a temperature. So it's really useful to know if they've got a temperature. The degree of fever is not so useful.
Thank you. And in terms of COVID pneumonia in children, does it present like any other respiratory infection? So are there the steps? So for example, in adults, we have this phenomenon called happy hypoxia, where, your young adult with COVID could be desaturating without showing signs of respiratory distress. Are there any atypical signs like that in children, as far as we're aware?
No, we would echo that. Yeah, when you asked that question, we all thought of that patient.
Yeah, we all met him.
we all met him. But yeah, we just haven't seen lots of people with respiratory illnesses, so that hasn't been.
No, and they've largely presented the way you would expect acute respiratory infection in children to present, so not cognitively taxing in any way. What I would say though is that I have seen an increased confidence of radiologists in diagnosing COVID from the chest X-ray alone, but they've been clinically indistinguishable to other pneumonias that we've seen, and they've been treated the same in that regard until we know their status.
Thanks, Gareth. Deepa. So yeah, I can mirror that. I've had a flurry of patients being admitted for other problems, and they have a CT scan or chest X-ray shows ground glass opacification, and that tends to be pathognomonic for COVID these days from a radiologist perspective. Now, last week when we were talking to Prof. Bennett, chair of BTS, he suggested that they're giving double dose dalteparin prophylaxis because there's an increased risk of thromboembolism in COVID. Are you seeing that in children, or have you changed your dalteparin guidance, your anticoagulation guidance in children?
So dalteparin does feature in our PIMS TS guideline, and certainly the ones that have ended up on ITU have had dalteparin given more as a prophylaxis as opposed to treatment. We haven't seen any thromboembolisms, but what we are seeing is children with a hypercoagulable state. So often their clotting or D-dimers and fibrinogen well, D-dimers and fibrinogen are certainly up. And until that starts to normalize, we will continue them on dalteparin treatment. And I know of, I think, 1 or 2 that have certainly received that.
Thanks, Deepa. So got a question from Dr. Bajrang Singh in London asking a very specific question. You have a child with patent ductus arteriosus and mild asthma. Would you class them as high risk?
That's not going to get a straight answer, I'm afraid. So how old is the child? How significant is the PDA in terms of cardiac function? And how severe is the asthma? I said mild, but what does that mean?
Let's say he's a 5-year-old child with mild asthma treated with PRN salbutamol with a PDA which isn't causing any heart failure under follow-up from the ped cardiologists.
Yeah. I think your face says the answer there, doesn't it, Tariq? It's hard in the grand scheme of the shielded plus, etc. It's hard to put that kid at enhanced in an enhanced risk category. Although obviously there are unknowns, and we do need to be careful that that child should enjoy a normal life, realistically, as normal as can be at the moment. Okay,
I mean, absolutely. I think you know, I think the challenge we might have in primary care is that parent is going to be immensely anxious, and the problem I suspect we have is we don't know everything about COVID yet, and if that child went on to develop coronavirus and there was a adverse outcome as a result, we are giving evidence on, we're giving recommendations based on a very a small amount of evidence, perhaps. So I think there is some anxiety about us as primary care clinicians giving that information to parents, but objectively I can understand your perspective from paediatrics. Just to sort of mention that there is actually a paediatric consultation safe assessment pilot at West Leicestershire CCG, and we're actually, well, it seems as if the team there with Prof Lakhani, Prof Rizvi and Dr Bura are thinking about piloting across primary and secondary care. So if there's an unwell child in primary care, having a video consultation with somebody in peds to perhaps determine whether they need to come in. And thereafter, a few more practices within the Leicestershire area to come on to that pilot. So if you're interested in that, then please do contact Prof. Rizvi, Prof. Lakhani, or Dr. Bura. So I'm just going to go through what other questions we may have.
Sorry, you want to say?
So just something a little bit unrelated. Sorry, yeah, please go on. I can see a hand. I can't see faces though. I like seeing faces, particularly because I can't meet anybody face to face.
So just talking about, again, when you're talking about risk with patients and you're not sure exactly what it is, what you could say to them is, okay, so you've got this heart condition which has not caused you any problems in the past, and the cardiologist has said it's not affecting your heart and the way it works. Okay, so therefore there's no reason to think that this disease will put you at any more risk than any of the other diseases, and therefore you should continue as normal. And that's what I would say. And it's about sharing the uncertainty with parents. You can't tell them that they're going to be fine when they get coronavirus, because you can't tell anybody that. But what you can say is that this PDA has not put your body under strain previously, and there's no reason to think that the coronavirus will do that.
And I think also whenever you're discussing risk, it's like two halves of the coin. So you can talk all we like about the unknowns of the risk of COVID, but there's so many risks of obesity, inactivity, not going to school. The amount of mental health presentations that we've seen, children either not seeing anybody, and then it seems to be recently going the other way, children who were out at parties,
going
drinking,
wild,
going absolutely crazy. It seems to be one or the other, and there are massive risks to children not being at school, not least the stress around the family and the lack of social interaction for some of these younger children, and the long-term consequences of that is again an unknown, but potentially significantly higher. So I think you can't just discuss the risk of them going to school, or whether, and their PDA and asthma, without saying the risk of them, what that will do to them if they're not at school, not mixing, not being educated, not walking around, being active. Their asthma, if they're not walking school every day and being active and doing playtime, probably isn't going to be great either. So I think you need to discuss the positives and the negatives, not just the unknown of COVID.
Absolutely. No, I think that's sensible, and that's informed decision making, I suppose, and we can help facilitate that discussion all the time. And I'm hoping webinars like this will help give us the knowledge that we need to share that. I'm sorry, Gareth.
I was just going to add, because I've seen in the chat, to tie in with that, we have very much seen a success in the media comms about COVID, obviously. And somebody had asked about comms related anxiety from the government and things. So when we're talking about risk, we have to be realistic that other diseases remain available. And I, for one, am extremely nervous about the reduction in activity. My adult colleagues are even more nervous because they're not seeing the strokes and the STEMIs that they would expect to be seeing. What's changed there? And I've certainly had conversations with families who are more nervous of a positive coronavirus test than a positive bacterial lumbar puncture result. And we're just in danger of really getting it wrong in terms of how we help our families understand risk in one way or the other.
Absolutely. Yeah, and I think, having confidence in this and will help us to make those decisions for patients and parents when needed. I mean, last week I had a chap who had a severe asthma exacerbation who was desaturating to 80% when EMAS came to see him, who didn't want to go to hospital because of the risk of COVID. I'm going to bring the session to a close very shortly, just a couple more questions. Now, we talk about ENT examinations, and at the moment there's guidance to say you don't need to be examining children's throats, and it talks about essential indications for pediatric throat examinations. What are the essential indications to examine a child's throat?
Okay.
If there's something sticking out of it, but otherwise there isn't one.
So
what were you thinking of?
Well, that's what the Royal College's guidance says, and they're not actually my words.
Yeah, so we've adapted that into a very pragmatic approach based on the fever pain score and the likely benefit of a direct visual assessment of the throat. But that obviously caters mostly to acute febrile illness. If you've got somebody who has a very specific issue, for example, an aspiration of a foreign body or something sticking out, or an injury, your aerosolizing procedures and your risk obviously remains, and that's one of the biggest challenges in paediatrics that we're finding, is that red and blue doesn't really matter too much with children, and also with our physical space. But if we think about the feverish illness type thing, then from a fever pain score, you're looking whether you can add 2 points in terms of purulent tonsils, or you know, a strawberry type tongue or inflammation of the mucosa. Just give them the 2 points without looking and putting yourself at risk in that regard. We also, though, caveat that with the likelihood that antibiotics are not disease altering in particularly the under 2s or under 3s. I do lose track of our guidelines sometimes, but I think it's under 3s, and to factor that in, especially if you're seeing someone in the early stages of fever, if that helps. There's going to be a case-by-case variation. Sometimes you're going to need to look in the throat or fish something out of the throat if someone comes in by ambulance having choked on something. But that, again, that has to be on a case-by-case basis, and relevant risk stratification decisions made at the time.
Thanks, Gareth. So I'm just going to touch on safeguarding. Now, people are locked up at home. There's increased risk of safeguarding issues. Are you seeing an increased number of safeguarding cases come your way as paediatricians in hospital?
It's just anecdotally, because from Deepa and I, when we've worked together there,
to be honest, they all come in when I'm on call.
But I mean, there certainly has been, so not just the safeguarding from a mental health, but also children who are not being seen. So they're not being seen by nursery or school, and then events have happened and no one is aware of that because they're not going anywhere. So although vulnerable children should be going to school, one, you have to be defined as vulnerable in the first place, which lots of vulnerable children aren't noted to be vulnerable, or recorded as vulnerable. And then the other thing is, even if you are vulnerable, it's difficult to mandate a child to still go to school or nursery. So the family I'm thinking of, the children were at attending a nursery, but the nursery being closed since March, they haven't gone anywhere, so haven't really had any interaction. So that's not only that they could come to harm from where they lived, but also all of the positive things that were happening in their life outside the home were no longer happening. And that puts it's difficult for the children, but also puts a bigger stressor on a family who are already under stress when they're not getting respite or support from the normal agencies, as well as school, including school and nursery, that normally would. So anecdotally, yes, but I'm sorry, I don't know any numbers, and I don't know if that's an experience others have had.
The other thing that is happening is that social care are being prevented from doing their job by people who are saying they're shielding and isolating from coronavirus. So, and
not letting people in.
When social care are going to investigate some of these children who have been labelled as vulnerable, they're not being allowed in the house, and they're having real problems trying to interact with some of these families. And then you're having a situation where they're trying to make quite difficult, complex decisions without seeing the environment, without seeing the children. And I think that is another problem, another thing that social care are really struggling with their cases that they know of.
Deepa.
Yeah, so unfortunately I have seen a lot of safeguarding referrals. Again, I can't quantify the number. I think the two most relevant to the COVID related social care admissions have been, one, a child being involved in an altercation between parents, and as we know, the rise in domestic violence is rising, so whether we're going to see more of that. And funnily enough, two of the social kind of safeguarding workup we've had parental COVID-induced psychosis, which was particularly interesting. So maternal pyrexia confusion. and as a consequent social concerns.
Thanks, Deepa. Thanks, guys. I mean, very much seems as clinicians, we will have to be on our guard when it comes to safeguarding issues and be very much looking at the signs of abuse and escalating it down the pathways that we know of, and particularly because we expect the number of abuse cases to have increased through this lockdown period. I think that question is going to end this session, and I think it's been a fantastic session. I think I'm hoping very much so that this is going to be the first of many webinars from the paediatric team at the hospital. And I think also during times of crisis, it becomes even more so important for there to be an integration between primary and secondary care. And thank you so much to all of the paediatric team at the Leicester Royal Infirmary. We're really well looked after as parents of Leicester. And also it's really good to have your expert opinion on board today. We've got a few lineups planned for everybody. We've got Dr. Richard Wong presenting towards the end of June about COVID, end of life and care home issues. We've also got some other presenters who have lined up. If you have any feedback with respect to the webinar, please will you kind of let us know. If you've got any topics that you want to discuss in particular, then just email us. The email address is going to be on the chat. And finally, CPD for your appraisals. If you want a CPD certificate as a result of this, then if you want to email the meeting chat. And I think on a final note, well done, guys. I think, you know, as a medical workforce, we are showing tremendous adaptability at a time of crisis. And I think it's really important for us to divorce ourselves from the politics of the situation, because often that overshadows everything else. So thank you all for your hard work and all the participants through this discussion. It truly has been a national event today. So have a lovely evening. It's not as sunny as yesterday, but you've still got an evening to enjoy. Thank you, everybody.